Thank you for joining us today on the Anesthesia and Perioperative Medicine channel. Today, continuing from our last lecture, we're diving into the second session of the 2024 Guideline for Perioperative Cardiovascular Management for Non-Cardiac Surgery. We'll be reviewing the recommendations for when our patients with major cardiovascular diseases undergo non-cardiac surgery. Now, I know this can seem like quite dense material, but I truly hope we can all study this with a real sense of mission, recognizing that we, as anesthetists, are very often the only doctors responsible for managing a patient's pre-existing cardiovascular problems during the immense stress of surgery.
Right. Here's our roadmap for this session. We'll kick off with coronary disease and the whole revascularization debate. Then we'll tackle perioperative blood pressure, which I know is a daily headache for all of us. From there, we'll move into the complexities of heart failure and cardiomyopathies, followed by a deep dive into valvular heart disease. And finally, we'll cover arrhythmias and those all-important implantable devices, before we pull everything together with the key takeaways. So let's get started.
First up, coronary artery disease. And really, this is one of the biggest questions that has lingered over our specialty for decades. For the patient with stable coronary disease heading for a major operation, should we be sending them for a preoperative tune-up? A prophylactic stent or bypass. To intervene or not to intervene? The old way of thinking seems so logical, didn't it? You see a blockage, you fix the blockage. Surely that will reduce the risk of a perioperative MI. It just makes intuitive sense. But over the last 20 years, high-quality evidence, real, robust clinical trials have started to tell a very, very different story. And these 2024 guidelines really cement a fundamental shift in how we should approach this. And here it is, that paradigm shift, laid out for us in the official recommendations. Just look at that top line. Class 3, no benefit. And the level of evidence is BR. The R there is critical. It stands for randomized trials. So based on randomized evidence, the guideline states that routine preoperative revascularization is not recommended for patients with stable coronary disease. This is built on the back of massive studies, particularly the CARP trial, which looked at patients undergoing major vascular surgery. It found absolutely no difference in long-term mortality or perioperative MI between the group that just had good medical management and the group that had prophylactic revascularization. So what's the big takeaway here? It's that our focus has to pivot away from intervention and towards medication. The new gold standard, our primary strategy, is optimal medical therapy, or OMT. That means our job in the pre-assessment clinic is to make absolutely sure these patients are on the right antiplatelets, the right statins, and the right beta blockers. Now, of course, this doesn't mean we never send a patient to the cath lab before surgery. The guidelines are very clear. If the patient meets the standard indications for intervention, if they have an acute coronary syndrome, unstable angina, or really high-risk anatomy like a critical left main stenosis, then they absolutely should be revascularized. But the key is that they should be managed just as they would be if they weren't having surgery. The days of the prophylactic tune-up are officially over. All right, next up, let's talk about something we grapple with on every single list every single day. Blood pressure. The eternal questions. When is it too high to proceed with an elective case? And what should our target be once we're in the operating theater? Oh, we've all been here. It's the classic preoperative nightmare scenario, isn't it? The patient is fasted, consented, the surgeon is scrubbing, the theater is ready, and the blood pressure is 185 systolic. Your gut tells you proceeding is risky, but postponing causes enormous disruption and delays care. So what do? Let's see how the new guidelines help us navigate this with a bit more clarity. And make no mistake, this is not a fringe issue. A full quarter of our patients coming from major surgery will have significant perioperative hypertension. That sheer volume is exactly why having a clear, evidence-based framework is absolutely essential, both for patient safety and for consistent decision-making. Right, here's the guidance we've been waiting for. The guidelines give us a specific threshold to work with. For a systolic blood pressure of 180 or higher, or a diastolic of 110 or higher, we now have a Class 2B recommendation to consider deferring elective surgery. The wording there is absolutely key. It's not a hard stop, it's not thou shalt not proceed, it's deferral may be considered. This empowers us, it gives us the latitude to use our clinical judgment to weigh the risks of acute, severe hypertension against the urgency of the surgery for that individual patient. Now, once we get the patient into the theater, the guidance becomes much less ambiguous and much more forceful. This is a Class 1 recommendation. It states that we should aim to maintain the mean arterial pressure above a floor of 60 to 65 millimeters of mercury. The whole idea of permissive hypotension has been debated for years, but the evidence is now overwhelming. We have robust data linking even relatively short durations of a MAP below this level to both myocardial injury and acute kidney injury. The message couldn't be clearer.
Hypotension is the enemy. We must not tolerate it. We must treat it early and treat it effectively.
Okay, let's move into what is arguably one of the most challenging areas of our practice, managing the patient with a failing heart. These patients have so little physiological reserve, and they are exquisitely sensitive to the hemodynamic roller coaster of anesthesia and surgery. They demand our absolute A game. Now, here is a hugely important practice-changing update. The SGLT2 inhibitors, you know the ones, the flozins like dapagliflozin and empagliflozin, are now a cornerstone of modern heart failure therapy. The new Class 1 recommendation is that we must hold these drugs for at least 3 to 4 days before elective surgery. And why? To mitigate the risk of euglycemic diabetic ketoacidosis. This is a life-threatening metabolic emergency that can be unmasked by the catabolic stress of surgery. This is a critical safety alert that needs to be hardwired into all our preoperative protocols right away. This table really drives home why we have to be so careful. Just look at the column on the far right, the adjusted odds ratio for 90-day mortality. Even for a patient with just mild left ventricular dysfunction, their odds of dying within 90 days of surgery are 50% higher than someone with a normal heart. And look at what happens when the LVF drops below 30%. The risk skyrockets to nearly 2.5 times higher. This isn't just numbers on a page. This data is a stark reminder of the profound impact we can have, for better or for worse, when we care for this population.
Okay, let's drill down into a very specific and notoriously difficult condition: hypertrophic cardiomyopathy, or HCM. For any anesthesist, the big, scary monster we're worried about with HCM is dynamic left ventricular outflow tract obstruction. This is what can lead to sudden, profound, and often irreversible cardiovascular collapse on the operating table.
This table is essentially our cheat sheet for getting these patients safely through surgery. The mnemonic to burn into your brain is full, slow, and constricted. We need to keep the ventricle full by maintaining preload and meticulously avoiding any hypovolemia. We need to keep the heart slow by ensuring they continue their beta blockers, which allows more time for diastolic filling. And we need to keep the systemic circulation constricted by maintaining afterload, which helps to stent open that outflow tract. If hypotension occurs, a pure alpha agonist like phenylephrine is our drug of choice. Whatever you do, avoid inotropes. They are absolute poison in his condition because they increase contractility and will make the obstruction dramatically worse. Right, so we've talked about the left side of the heart. Now let's completely switch gears and focus on the right side. When you have a patient with significant pulmonary hypertension, your entire anesthetic plan needs to be reoriented around one single goal: protecting that fragile, overworked, and failing right ventricle. For these patients, the guidelines give us two absolutely critical, non-negotiable rules. Rule number 1 is a Class 1 recommendation. You must continue their targeted pulmonary hypertension therapies throughout the perioperative period. These are incredibly specialized drugs, and stopping them suddenly can trigger a catastrophic and often fatal right ventricular failure. Rule number 2, a Class 2A recommendation, is that for anything other than very low-risk surgery, you should strongly consider getting these patients managed in, or at least discussed with, a specialized PH center. They are just too complex and too high risk to manage in isolation. Next, let's briefly touch upon the rapidly expanding group of patients with adult congenital heart disease, or ACHD. Thanks to modern pediatric cardiology and cardiac surgery, these patients are surviving well into adulthood and are now presenting for all kinds of non-cardiac surgery, bringing their weird and wonderful and often incredibly complex physiology with them. This risk stratification table from the guidelines is an incredibly useful tool for the preoperative assessment. It allows you to quickly get a sense of where your patient lies on the risk spectrum, from a simple repaired ASD at the low-risk end, all the way up to someone with a single ventricle and a Fontan circulation at the highest risk end. This helps us to triage these patients appropriately and identify who needs that essential preoperative consultation with an ACHD specialist.
All right, let's move on to the heart's plumbing, valvular disease. The 2024 guidelines provide some brilliant, clear, and very practical algorithms to help us make decisions, especially when we're faced with a patient who has severe, uncorrected valve disease.
Let's start with the big one: severe aortic stenosis. And here, the guidance could not be more direct.
It's a Class 1 recommendation that any patient with known or suspected severe AS must have a comprehensive valve evaluation before undergoing elective non-cardiac surgery. We absolutely cannot anesthetize these patients blind. They are a house of cards. They have a fixed cardiac output and are incredibly vulnerable to the vasodilation we induce. A drop in their afterload can trigger a death spiral of hypotension, coronary malperfusion, and ischemia. We have to know exactly what we are dealing with. And this flow chart is our roadmap for managing them. It looks complicated, but the core logic is actually quite simple. It boils down to this. If the patient has symptoms from their severe AS, or if their LV function is impaired, then the default pathway is to fix the valve first, before they have their elective non-cardiac surgery. The only situation where we might consider proceeding with the non-cardiac surgery first is in the truly asymptomatic patient with a completely preserved ejection fraction.
Now for severe mitral stenosis. The entire pathophysiology is about the restriction of flow from the left atrium to the left ventricle. This means their cardiac output is completely dependent on having enough time for diastolic filling. So our number one anesthetic goal is strict rate control. Tachycardia is an absolute disaster for them. Similar to AS, if they're symptomatic, we should consider valve intervention first, and if we do decide to proceed, using invasive monitoring to guide our fluid management is a very sensible approach.
For the chronic regurgitant lesions, so chronic AR and MR, the problem is the opposite of stenosis. Here, the ventricle is volume overloaded, not pressure overloaded. So our anesthetic goal is to promote forward flow by reducing afterload. A little bit of vasodilation is actually our friend here. The decision to intervene on the valve before non-cardiac surgery is also simpler. It really comes down to two questions. Is the patient symptomatic from the valve disease, and is their LV function starting to fail? If the answer to both is no, then it is generally safe to proceed with the non-cardiac surgery.
Right, onto our final major topic before we summarize. Let's talk about the heart's electrical system. We'll look at the very common issue of perioperative atrial fibrillation, and then we'll get into the nitty-gritty of managing patients with cardiac implantable electronic devices, or CIEDs.
Perioperative AF is something we see all the time. Our management goals are really twofold. Goal 1, as this Class 2A recommendation points out, is hemodynamic stability. That means controlling the ventricular rate, usually with beta blockers or calcium channel blockers. Goal 2 is stroke prevention. For any patient who develops new-onset AF, we must assess their thromboembolic risk, typically using the CHA2DS2-VASC score. If that risk is high, we have a responsibility to ensure anticoagulation is started as soon as it is surgically safe to do so.
Okay, let's talk about our patients with pacemakers and defibrillators. In the operating theater, our public enemy number one is electromagnetic interference, or EMI, which comes primarily from the diathermy. EMI can confuse the device. It can inhibit a pacemaker when it needs to fire, or even worse, it can trick a defibrillator into thinking there's a fatal arrhythmia and delivering a completely inappropriate and dangerous shock.
This table lays out the complete systematic approach we should be taking, and you'll notice that the core principles are all Class 1 recommendations, meaning they are non-negotiable. We must interrogate the device preoperatively to understand its function and settings. We must disable anti-tachycardia therapies in all ICDs to prevent inappropriate shocks. And for our pacemaker-dependent patients, we must ensure they are in a safe, asynchronous pacing mode that cannot be inhibited by diathermy. This requires a proper plan, ideally made in conjunction with the cardiology team.
So we can boil that all down into a very simple safety mantra. First, interrogate the device before surgery. Second, disable the shock therapies for any ICD. Third, ensure asynchronous pacing for any dependent patient. And fourth, and this is the step that sometimes gets missed, you must always re-interrogate the device after the surgery to ensure it's back to its baseline settings and functioning as it should be.
Right. We have been on quite a journey through some very detailed recommendations. So to finish, let's just crystallize this all down into the 5 most important practice-changing messages from these guidelines that you can take away and implement in your department tomorrow. If you only remember 5 things from this whole talk, please let it be these. Number 1, stop routinely revascularizing stable coronary artery disease. Focus on optimal medical therapy instead. Number 2, hold SGLT2 inhibitors for 3 to 4 days before surgery. Number 3, respect the 180 systolic blood pressure threshold as a point to pause and consider postponement. Number 4, use the fantastic new algorithms for managing severe valvular disease. And number 5, have a robust, systematic plan for every single patient with a CIED. If you can master these 5 things, you will be making a huge difference to patient safety.
So I will leave you with one final thought to reflect on. After everything we've discussed today, what is the single biggest change that you are going to make in your own clinical practice starting tomorrow to better align with this new evidence and to improve the care that you provide for your patients? Thank you very much for your attention.